Hello, my name is Dr. Ukiri Richard, the only Nigerian to give you a podcast on basic cardiology. And today I'm going to talk about transient absence. The case I'm going to use is that of a 77-year-old male patient that was sent to your clinic from the house doctor for a complete cardiologic checkup. He came in company of his wife and his daughter. He is telling you that he does not have any complaint, but the daughter and the wife told you that in the last month he has been having episodes of which he has become non-responsive for some few seconds. Additionally, a week ago, he even fell down, though he didn't have any injury. My first question to you now is, what would you want to know? Number one, I would like to know how the event happened. 2, I would like to know if there are any triggering factors. 3, I would like to know if the patient noticed anything before, like heat, internal heat, palpitation, dizziness, even blackness in front of the eyes. Or 4, I want to know the past medical history and medications. Well, the daughter told you that the father, while they were sitting together in a round table, became suddenly non-responsive, but thereafter became completely awake. The patient told you that he cannot remember anything. Well, he knows that he fell down last week because he tripped. He has palpitations from time to time, especially when he climbs stairs. But he never experienced dizziness. He does not take medications regularly. He does not take any medication. For some years ago, he took some tablets against high blood pressure. But because the blood pressure normalized, he stopped the tablets. What test do you think would be helpful in this patient? Well, according to the German Society of Cardiology guidelines, we have to do basic diagnostic clarification, in which we want to know if the loss of consciousness actually was a syncopal attack, if there is an organic heart disease, and if the history or clinical examination will give us guide to a direct or a specific diagnosis. The basic diagnostic tests according to the German Society of Cardiology, are good history, physical examination, resting ECG, as well as blood pressure measurement in erect and supine. In the physical examination, you found an 175 centimeter tall man with a weight of 80 kilograms, where he was in good condition, blood pressure erect, supine 145/85 with heart rate of 70, erect 140/80 with heart rate of 80. There were no congested jugular vein and no edema. Good. I want to run down. Please listen very carefully. The possible causes of syncope when you have unclear syncopal attack, and how you can get it from the history. That means how you can know the cause of syncope or the most probably cause of syncope from the history. Now listen very carefully. If you have a syncopal attack after unexpected pain, fear, sight, noise, or smell, it is most likely going to be a vasovagal syncope. If you have a syncopal attack after long standing under tension, it is also likely going to be a vasovagal attack. If you have a syncopal attack during micturition, defecation, coughing, or after vomiting, it is a situation syncope. If you have a syncopal attack, when you change position from supine to erect, it is most likely going to be an orthostatic syncope. If you have a syncopal attack after you move the head from left to right or right to left, after movement of the head, or pressure on the carotid sinus, maybe during shaving, washing, or tumor, it's most likely going to be a carotid sinus syndrome. If you have a syncopal attack after taking your medication, especially medication that leads to prolonging of the QT interval and can cause orthostasis and bradycardia, you think of a medication induced syncope. If you have a syncopal attack that is short-lived without prodromy, it is most likely going to be an arrhythmia. If you have a syncopal attack in a patient that has positive family history of sudden heart death, please think of long QT syndrome, arrhythmogenic right ventricular cardiomyopathy, and Brody-Gardner syndrome. If you have a syncopal attack at rest without bodily exertion, if you have a syncopal attack under exertion, you think of aortic stenosis, hypertrophic obstructive cardiomyopathy, pulmonary hypertension, mitral stenosis, and coronary heart disease. If you have a syncopal attack with auscultatory heart sounds, heart murmurs, and happens after change of position from supine to erect, you may think of either a thrombus or an atrial myxoma. If you have a syncopal attack after headache, you think of migraine or epilepsy. If you had a syncopal attack that is associated with confusion after the syncopal attack, and the syncopal attack lasted more than 5 minutes, and epilepsy or a convulsion is most likely. If you have a syncopal attack that is connected with dizziness, dysarthria, and double diplopia, there you have to think of a transitory ischemic attack, a subclavian steal, and also a cerebral hypoperfusion. If you have a syncopal attack that comes up when you move the arm, then it is definitely a subclavian steal. If you have a syncopal attack with blood pressure or pulse difference between both arms, think of either a subclavian steal or aortic dissection. But when you have a syncopal attack that is frequent and with somatic symptoms without any heart disease, please think of a psychiatric condition. So you did the ECG of this patient. First of all, the physical examination, auscultation of the heart was normal. The lungs with percussion and auscultations were also normal. Peripheral pulses were also good, palpable, and the other examination tests were normal. The ECG, you found the sinus rate in different axes. The time intervals were normal, and there were no changes in the repolarization. There was only some peripheral low voltages. According to the German Society of Cardiology recommendation, the result of the basic diagnostic test should actually be enough to make a diagnosis on the cause of a syncope in the following cases. 1. You have a classical vasovagal syncope when the syncope occurs after fear, strong pain, emotional pressure, intervention like venipuncture, also long-standing, as well as typical prodromi. 2. A situation syncope can be diagnosed when the syncope occurs after micturition, defecation, coughing, or vomiting. 3. An orthostatic syncope could be diagnosed when a documented orthostatic hypertension was documented in relation to the syncope or the presyncopal phase. The patient should lie down 5 minutes before the orthostatic blood pressure measurement, and the blood pressure should be measured after 1 or 3 minutes standing position, and the blood pressure measurement should continue 3 minutes after fall. When the patient can no longer tolerate the standing, the lowest blood pressure should be recorded. A reduction of the blood pressure above 20 millimeters of mercury, or a fall of the systolic blood pressure below 90 millimeters of mercury, can be documented irrelevant of occurrence of clinical symptoms as orthostatic hypertension, and therefore the syncope can be called an orthostatic triggered syncope, especially in case of dehydration, antihypertensive medication. 4. A cardiac stroke ischemia triggered syncope can be diagnosed when the syncope is associated with ECG changes that have indication for an acute myocardial ischemia with or without myocardial infarction. And 5. An arrhythmia-induced syncope can be diagnosed when the following ECG changes are documented. 1. Sinus bradycardia less than 49 per minute, or recurrent SA block, or pulse more than 3 seconds. 2. AV block 2, morbid type 2 or 3. 3. Alternating left and right bundle branch block. 4. Fast paroxysmal supraventricular or ventricular tachycardia. And 5. Pacemaker dysfunction with pulses. So let's come back to our patient. From what we have seen now, can you tell us from this basic diagnosis the cause of this patient's syncopal attack or the absence? No, the result we have gotten cannot give us any definitive cause about the cause of the patient's problem. So we need more tests. What tests are you going to require according to the guidelines, or what tests do the guidelines recommend? According to the German Cardiology Society, the recommendations are as follows. 1. In patients where you suspect a heart disease, you do firstly the echocardiography, ECG monitoring, and when this cannot lead you do electrophysiologic examination. 2. General laboratory tests are usually indicated when there is when the syncope may be related of loss of circulatory volume, like in dehydration, or where you think the syncope may be caused by a metabolic disorder. 3. In patients with palpitations in connection to the syncope, the first line diagnosis there should be ECG monitoring, then echocardiography. 4. Patients with chest pain as indication for a coronary ischemia before or after the loss of consciousness should actually be given a stress test, echocardiogram, and ECG monitoring. But don't forget that in patients with chest pain, you have to actually exclude an acute coronary syndrome. Until that, you cannot do a stress ECG. Instead, you will need to do a coronary angiography. 5. By young patients without indication or suspicion of a cardiac or neurological disease and that have recurrent syncope, you will need to do a tilt table test. In old patients, a carotid sinus massage is recommended. In patients with syncopes that happen after the turning of the head, you may do to do the carotid sinus massage is recommended. When you have clinical signs of vasovagal syncope, you can forget the tilt table test. The indication for a tilt table test in patients with unclear syncope should be done when a cardiac or neurologic cause seem unlikely. 6. In patients that have syncope after body exertion, you really need to do echocardiogram and stress test to exclude a left ventricular outflow tract obstruction like aortic stenosis. 7. With patients that have signs of autonomic dysfunction or neurologic sickness, you have to do specific neurological tests. And 8. Patients that have frequent recurrent syncopes, that have multiple other somatic complaints, and when after the first evaluation you saw indications of stress, fear, and possible psychiatric problems, you please request for a psychiatric examination. So let's come back to this our patient. What more tests are you going to suggest for this our patient? According to the guidelines, in old patients, we need to do a carotid sinus massage. In case you suspect a heart disease, you need to do an echocardiography and ECG monitoring. The echocardiography is very good for risk stratification. Because of the age of the patient, a coronary heart disease, despite a patient not having angina pectoris, is not impossible. So that a stress ECG test should be done. What diagnosis? You have mentioned a lot from what you just said. What diagnosis can you exclude or confirm with the suggested test you just mentioned? The carotid sinus massage, a negative massage will make a carotid sinus syndrome very unlikely. Echocardiography will exclude aortic stenosis and a hypertrophic obstructive cardiomyopathy. It will check the right ventricle and left ventricle function and help to diagnose a pulmonary hypertension. The ECG Holter will show you if there is significant bradycardia or tachycardia or any bradycardic or tachycardic arrhythmia. And stress test will tell you if there is a relevant coronary heart disease, if there is a chronotropic incompetency, and if there is induction of heart rhythm disturbances like arrhythmia under stress. It will also give you the blood pressure relationship to stress. Good. How do you carry out the carotid sinus massage? Before you do the massage, you have to auscultate both carotids. You have to ensure that you do not carry out a compression of the carotid sinus, but just a soft massage. When you have a negative finding, you go to the other side after 1 to 2 minutes break. Don't forget that while doing the massage, you have to have a continuous ECG documentation and monitoring. In blind patients, the carotid sinus massage should be taken more than 5 seconds. A positive carotid sinus massage is when you have an asystole more than 3 seconds, or when you have a blood pressure or when you have a blood pressure fall of more than 50 millimeters of mercury. Alternatively, you could do the carotid sinus massage above 10 seconds, but then in erect and in supine position and trying to look for symptoms. Okay, let me tell you what you got in this patient. Let's come back to our case. The echocardiography, the left atrium was slightly dilated 43 millimeters. The left atrium was normal. There was good left ventricular global function, no regional wall disturbances. The left ventricular thickness wall thickness was 12 millimeters. Aortic valve was slightly sclerosed. There was slight insufficiency, and mitral valve was normal. There was light tricuspid valve regurgitation, and the gradient through the arrow right ventricle to right atrium was 28 millimeters of mercury. There were no pericardial effusion. So, conclusion: there was mild left ventricular hypertrophy, mild left atrial dilatation, and aortic valve sclerosis. You did the stress test up to 120 watts. The maximum heart rate was 145 per minute, and you could not, because there were no repolarization disturbances. Don't forget that the patient was not stressed maximally. 125 watts and 145 per minute heart rate. So the conclusion is that due to reduced competence of the test, you cannot say if there's a hemodynamic relevant coronary heart disease. You did the ECG Holter. The sinus, it was continuous sinus reading, heart rate 45 to 145 per minute. There were no asystole more than 1.5 seconds. You have 25 ventricular systole and 155 supraventricular systole. Conclusion: there were no indication for a syncopal cause. And the carotid sinus massage you did, with light pressure of the right side, you had an asystole from 7 seconds. The patient lost consciousness during this massage. My question now is, what therapy are you going to suggest for this patient? It is very clear. Because of the significant and very crystal clear symptoms that the patient exhibited during the carotid massage, and also the history of recurrent syncopes, there is a class 1 indication for heart pacemaker implantation. Let me tell you the indication for pacemaker implantation according to the European Society of Cardiology and the German Society of Cardiology. If you have recurrent syncope that are related to stimulation or provocation of the carotids, and that happens during a normal head movement and are triggered through the massage of the carotids, and also cause an asystole more than 3 seconds, this is a class 1 indication. If you have a recurrent syncopal attacks which starts with undefined causes but with positive symptomatic presentation due to hypersensitive carotid sinus reflex, this is a class 2A attack. That is positive carotid sinus reflex. That means pulse of more than 3 seconds. This is a class 2A indication. Please don't forget that a positive carotid sinus massage without the presenting clinical symptoms, even when you have an asystole of more than 3 seconds, does not really give you the indication for a pacemaker implantation. And don't forget that in patients in supine position that are lying down, if you do carotid sinus massage on them, in more than 38% of cases you will have a pathologic finding. So good, you have decided now that this patient needs a pacemaker implantation. And the wife is asking you now, what are the risks of this implantation? What are you going to tell her? As in all intervention, there could be complications. In this case, you expect rhythm arrhythmias like asystole or ventricular fibrillation, which has been seen in 0.2% of cases. The most common surgical problems are electrodislocation, especially in atrium, 1.5%, and in ventricle, 1.1%. There could be an intervention There could be a pneumothorax that we need intervention, 0.4%. There could be a hematome formation around the aggregate, infection, perforation of the heart muscle, which is likely very, very seldom and usually not to talk about, not worth discussing. Okay, which kind of pacemaker are you going to suggest now? Is it 1 chamber, 2 chamber, or which kind of additional functions? Preferably, I would need a 2-chamber pacemaker implantation so that a physiologic stimulation of the atrium can be conducted to the ventricle. Preferably, I would like a frequency hysteresis function to prevent jump in heart rate. A pacemaker without this function will be implanted with the programmed heart rate so that the heart rate of the patient can fall from, for example, 90 to 60, which is common in this our patient, which is very, very intolerable in this our patient and can cause syncope. A frequency adaptation in this our patient with normal heart rate trend according to the ECG Holter will not be necessary. If you have a normal resting ECG, an AV hysteresis will not be necessary. If you have checked the resting and the ECG Holter, a pacemaker with the adequate algorithm should be used. An AAA pacemaker in patients with carotid sinus syndrome is not enough, because apart from the inhibition of the sinus node, sometimes you have intermittent AV blockage, which in this patient we could not even judge because he had sinus arrest, so we could not judge the AV conduction. If you use a VVI pacemaker, you can have an aphysiologic stimulation of the ventricle, which will be hemodynamic, very unbeneficial, and syncopal attacks can also come up, and it could also have pacemaker syndrome. Okay, the doctor still asks you now, what do you think will be next time to check or control the pacemaker? According to the guidelines, 1-chamber pacemaker after implantation, in fact, in all 1-chamber, 2-chamber ICD or CROT after implantation 1 month. But the regular control in 1-chamber pacemaker 6 to 12 months, 2-chamber pacemaker 6 months, ICD or CROT 3 to 6 months. Well, clinically, you can give a shorter or longer interval, which is actually dependent on if the patient is dependent on the pacemaker or not. But when the pacemaker has worked for long, or when you are seeing signs of that the battery is getting exhausted, you give time lower than 3 months. Thank you very much.